Hello and welcome to the third installment of the Transplant C-Suite Snapshot Webisode series. For this installment, we're focusing on the topic of transplant regulatory oversight and requirements. We're pleased to be joined by Linda Ohler, Associate Director of Quality, Regulatory, and Education for New York University Transplant Institute. With 30 years' experience in transplantation, Linda has served at various transplant programs as a clinical transplant coordinator in heart and lung transplantation and VAD coordination. She's also served as a clinical nurse specialist and nurse manager in kidney, pancreas, and islet cell transplantation as a program manager for the heart transplant program at Virginia Commonwealth University before joining the team at NYU. She served on the board of directors for the International Society for Heart and Lung Transplantation and for the Washington Regional Transplant Consortium, as well as on 4 UNOS committees, including operations and safety committees. In 2001, Linda was inducted as a fellow in the American Academy of Nursing, and in 2012, she received the American Society of Transplantation's Clinician of Distinction Award at ATC in Boston, and in 2017, she was selected as a fellow of the American Society of Transplantation. She has co-edited and written 4 books on transplantation and served as the editor of Progress in Transplantation for 23 years. Linda, it's a pleasure to have you with us, and at this point, I'll turn it over to you to begin our program.
Thank you, Corey. Our objectives for this program today are going to be 1, describe the history leading to the regulation of solid organ transplantation. 2, discuss how the final rule has been implemented. 3, identify how data is obtained and analyzed. And 4, evaluate strategies for hospital leadership to support transplant teams. So first, we're going to talk about the history leading to the regulations of solid organ transplantation. In 1984, Congress passed the National Organ Transplant Act. You will hear this referred to as NOTA. This act established the Organ Procurement and Transplantation Network to maintain a national registry for organ matching. The purpose of this registry was to provide fair and equitable access to transplantation and to forbid the sale of organs. NOTA called for the network to be operated by a private, nonprofit organization under a federal contract. In 1986, the United Network for Organ Sharing in Richmond, Virginia won this contract. This contract required administration of organ procurement organizations, transplant centers, and the Scientific Registry for Transplant Recipients. The rule also required for public reporting of analyzed data from transplant programs and organ procurement organizations. During this time of implementation, programs flew under the radar of any oversight. To start a program, you had to apply to CMS and perform, let's say, 12 heart transplants a year for 3 years and demonstrate good outcomes. Once approved, there were no additional requirements at that time. To better understand the structure of this system, here is a graphic that demonstrates the relationship between the Department of Health and Human Services, HRSA, the Division of Transplantation, and contracts to the OPTN and SRTR. The structure remains the same today. In 2000, the final rule was implemented by the federal government that established a more regulatory framework for the structure and operations of the OPTN. Between 2003 and 2008, the Los Angeles Times investigative reporters began exposing stories that demonstrated a probable void in monitoring or oversight of the regulations. Journalists Charles Ornstein and Tracy Weber published a series of articles that demonstrated problems in the systems. These articles and problems were brought to the attention of Senator Grassley of Iowa, who asked the Government Accounting Office to evaluate transplant. Initially, there was a lot of finger-pointing about who had oversight for the regulations. There were some who pointed at UNOS, while others looked at the government agency, that the government agency had oversight. In 2007, CMS issued the Transplant Center Conditions of Participation in the Federal Register. This document required that all transplant centers must submit a letter to CMS stating they would abide by the new conditions of participation. Centers began writing policies, protocols, and guidelines to reflect the new conditions of participation. So let's look at how the final rule has been implemented. In 2008, CMS issued interpretive guidelines to the conditions of participation. These guidelines helped us to better understand the regulations outlined in the Federal Register's condition of participation. We do anticipate new interpretive guidelines to be released in 2019. Prior to 2007, there was very little oversight, and I don't recall any site surveys at transplant centers. However, with the new regulations and the exposure from the media, we now began having site surveys. We began having site surveys from UNOS and CMS. CMS initially deemed the state departments of health as the surveyors. The Joint Commission also began issuing new guidelines, and these were more for disease-specific programs such as heart failure, ventricular assist devices, and soon we found ourselves having surveys from UNOS, CMS, Department of Health, and the Joint Commission if you had a bad program. And these programs, at one year, I had 3 different surveys. So UNOS is a planned 3-day site visit. This is good. We get a list of patients given to us a month ahead of time, and then we get followed up with desk audits for any areas that are somewhat deficient. And then it all goes to the MPSC for decisions. That's the Membership and Professional Standards Committee. So they make a final decision as to whether we are doing okay. We also have living donor surveys, and this is a list of donors also given to us and the recipients, and then we have 3-day site visits. They've pretty much combined those 2 at this particular time. CMS initially said that they wanted the Department of Health for each state to look at us. Then we went to having consultants, and now we're going back to having the Department of Health. These are unannounced visits, and they're usually present for 5 to 7 days. The Joint Commission is an every 2-year visit to programs for ventricular assist devices. Once these surveys began, CMS issued a systems improvement agreement to programs who failed to comply with the regulations. Between 2007 and 2016, 145 programs were cited for deficiencies. What happened is there was confusion from CMS and UNOS. They would give us regulations that we had to follow, but they were somewhat confusing. So programs began to be surveyed, and we would see that they were being cited for deficiencies. So between 2007 and 2015, 145 programs were cited for deficiencies by CMS for their patient or graft volumes, because we have a certain volume that we have to maintain for each organ system. The outcomes were below expected, more patient deaths, more graft failures. 83 of these programs, 83 of the 145, were actually able to improve within the 210-day period determined by CMS. They were able to improve their outcomes. They were able to do performance improvement projects that improved things. And many programs, unfortunately, became risk averse. What would happen is people didn't want to take organs that weren't pristine because they didn't want any more deaths or graft failures. As a result, we began to waste or discard organs. Of the original 145 programs cited for deficiencies, 45 completed a 1-year Systems Improvement Agreement, or SIA, costing well over $1 million for each SIA, especially due to losses from private insurers. 17 programs actually terminated their participation with CMS. So how do CMS, UNOS, patients, transplant centers, and private insurers know what our program outcomes are? Well, the interpretive guidelines actually state that about data submission. The standard states, the Interpretive Guideline X032 states, data submission no later than 90 days after the due date has been established by the OPTN. A transplant center must submit to the OPTN at least 95% of required data on all transplants, deceased and living donors that it has performed. This includes the candidate registration, the transplant recipient registration, follow-up, living donor registration, and all follow-up has to be reported. So each transplant program has someone that helps to submit data. This is really important, as you can see, because we are held accountable for submitting this data within a very specific period of time. So data submission on each of the following forms had to be submitted, and this data had to be pristine. And we had to hire people who understood the value of pristine data being submitted. Data had to be submitted on living donors, the transplant candidate registration, the transplant recipient registration, and transplant recipient follow-up. In other words, after a patient was transplanted, they are followed at, we register them, and then at 6 months, we put more information on how they're doing, put more data into the UNET system, and then at 1 year, and then annually thereafter. If a patient develops, a recipient develops malignancy post-transplant, we also have forms to do at that particular time. The data then is submitted to the SRTR. The required submission goes directly to the data. It's really interesting, goes directly to the SRTR. It is really interesting how this is done. You or anyone in your hospital, anyone in your city, anyone in the United States, patients, insurance companies, CMS, anyone can look at this data, including people outside the United States. So to look at the data, you go to their website, www.srtr.org, and you can select the organ that you want to look at. In this case, we're going to look at liver. We're going to put in a postal code or program name. I'm going to put in 10016, and I'm going to search, and I'm going to come up with NYU. So I can show you what these reports actually look like. So this is a report that anyone in the United States, outside the United States, insurance companies can look at. Initially, the SRTR used an O/E ratio, but now they're analyzing data using a Bayesian method of statistics that results in hazard ratios. So here on the lower portion of this document, you can actually see the estimated hazard ratio of 0.82, and this is, as I said, NYU's liver transplant program. So here it says 0.82. A hazard ratio result should be less than 1. The only limitation of this data is it's always behind. If you look here, the cohort is from July 1st, 2015 to December 31st, 2017. So that's kind of old information. It's now 2019, and that's what we have to go by. What's interesting, though, is it does compare to national. So here's the U.S. data. So NYU during this period did 80 liver transplants, and the probability of surviving with a graft at 1 year is 92.5%. Nationally, it's 90.75%. So NYU is doing pretty good there. And surviving with a functional graft at 1 year is 89.72%. They don't have national listed there. The observed graft failures, we had 6 at NYU. Expected was 7.76. So we did better. So therefore, our estimated ratio comes out at less than 1, which is good. So we would not be cited for any poor outcomes for that particular time period. So COP 482.96, that's the condition of participation 482.96, states that transplant programs must have a written, comprehensive, data-driven quality program. And that has to be done in collaboration with the hospital QAPI program. There needs to be a bi-directional flow of information between the hospital and the transplant quality programs, which means that when we present our data at NYU to our staff, to our operating room, to our transplant teams, we have to give them also what's going on in the hospital. So we report on infections, we report on any kind of problems that are seen in the hospital. We are giving the hospital data. But twice a year, we also go to the hospital quality program and we absolutely present our data. So we show them what's going on in the liver transplant program, the heart program, the kidneys, all of those different programs, we give them our outcomes. So that demonstrates that bi-directional flow of information between the hospital and transplant quality program. We also collaborate with hospital risk. For instance, if we were to have an adverse event in our transplant program, we would invite someone from hospital risk to work with us on our performance improvement on that particular thing and our corrective action plan. So they would come in and work with us on developing a thorough analysis of our problem. So we have to also have our own transplant adverse events policy that identifies exactly what we consider to be an adverse event in transplant. Most of us consider any transplant death within the first year, any graft loss within that first year. So we have an adverse events policy which identifies what constitutes a thorough analysis. So not only do we identify what an adverse event would be, but what we do about that, how we analyze that problem. COP 482.96 states that programs must have a written, comprehensive, data-driven QAPI program. Ensure that the QAPI plan discusses collaborative relationships with the transplant QAPI plan. So the hospital QAPI plan must demonstrate that they know we have a transplant program at this hospital, and that is reflective of the fact that we have that program and that the hospital recognizes that. We must ensure that the transplant quality team provides written verbal reports to hospital leadership in their hospital quality program. We must assign a member of the transplant quality team to be a member of the hospital quality program. So in other words, we have a representative from our transplant program to be on the hospital quality committee. And it's important for leadership to review these updates on transplant outcomes at least twice a year with the transplant quality manager and administrator. And again, this can be done through the actual program if we present to the hospital quality program. So CMS Arrival Protocol. We don't know when CMS is going to come. Initially, we thought every 3 years, and pretty much that's what was happening, is they were coming to us every 3 years. Now they're telling us that they probably will come every 3 to 5 years if a program is not having any problems. So it's really good to be ready for them. When they came to visit us last August, we had been practicing this arrival protocol, and we had everything ready for them within the first hour. That makes a program look very organized. So this is really important. You write out the steps for specific staff members to follow when CMS arrives. So as soon as you get that notification that CMS has arrived at the hospital, we then put everything into action. We notify everybody. We have a notification mechanism. And then we practice this once or twice a month so that everyone is prepared. And we practice when key members are on vacation to ensure that there is a backup person who is prepared. CMS expects these documents within the first hour. So it's really good to practice this, have everything ready for them when they arrive, because it makes the program look really very well organized. This is an example of the 31 items requested within the first hour of the CMS site visit. These are the things that we print out. We have to give them lists, meeting schedules, we have to give them minutes of meetings and things like that. All of this is printed out and given to the CMS surveyors within the first hour. That's why it's really good. You can see there's a lot of things that they require. So it's really good to practice this on several occasions. Because we don't know what the new conditions of participation interpretive guidelines are going to be, it's hard to practice this right now because we don't know if they're going to have the same expectations as they have had for the past few years since 2007. So we will hopefully find that out very soon. Many of us are quite anxious for this to evolve so that and the information to be released. So patient safety reporting. What can you do as a hospital leader? 1, develop a blame-free culture that focuses on systems problems to create a safe environment for both patients and clinicians. If you have a blame-free environment, people aren't so afraid to go to these thorough analysis meetings or these corrective action plans. They want to be able to practice in a safe environment for both patients and clinicians. So if we can look at it from a systems perspective and not place blame on someone, it's a lot less threatening. We want to encourage reporting of near misses, what lessons can be learned to avoid a crisis. So we want to look at these near misses and look at them with our risk department to see what can be done to avoid any kind of problem in the future with the same type of near miss issue. We want to assign staff from hospital risk and quality to work with the transplant teams and participate in analysis of near misses. Provide training in patient safety and as a high reliability organization. Provide training in performance improvement processes. These are important for our teams to be able to practice safely. What has been the positive outcome of all this oversight? Well, we have improved outcomes in transplant. That is a very good positive outcome. Transplant is also no longer in a silo. So we used to be this little silo that kind of practiced by ourselves. And now everybody knows about us. We're presenting to the hospital quality committee. We're presenting our outcomes. Our outcomes are known. We go to the different units. I present data to our intensive care units, to our step-down units, to our operating room nurses and staff that take care of our patients. I present our outcomes so they can see the benefit of the work that they're doing. It also has caused an increase in patient safety. So that's been another positive outcome of this oversight. There's an increase in patient safety, and I think also in clinical practice. More focus has been on data integrity. Oh, this is so important. The data that you enter has to be so good and so clean that it's going to show that the outcomes are pristine. So more involvement in quality, that's another positive outcome. And we have an improved focus on rules and regulations, and I think an improved respect for rules and regulations. And I think that has been very helpful to make our programs much safer. I really appreciate your support of transplant programs. We are highly regulated and we need your support. Thank you very much.
Thank you for joining us for this Transplant C-Suite webisode. Our thanks to Linda Ohler for her time, expertise, and an incredibly insightful presentation. If you have further questions, we invite you to connect with us on our website by visiting organdonationalliance.org. Thank you.